All right. So there's a ton of zoonoses, okay? They're transmitted from animals to humans. All right. And then how do they get transmitted depends on how you have contact with the animal, okay? So the thing is that we can actually transmit things to our pets, okay? So there's been lots of cases of Campylobacter that's been spread from owners to their dog. So, the dog may not want to hang around you either sometimes, okay? So the risk of if it's going to occur or not in the household depends on several factors. The frequency of the contact with this animal, the intimacy, okay, I'm not going to go there, and then whether or not the animal has contact with infected animals. So if you've got a cat that's inside the house all the time and never gets out, well, it's not likely to get exposed to weird things. But if you've got the cat that's like the feral cat that goes out and brings birds and rabbits, drops it on your pillow, whatever, then it's likely going to be exposed to some of these diseases that we're going to talk about. But the good news is overall it's low risk in U.S. pet owners. Okay. So if we look at pets in the United States, 55% of all households have a dog or cat. A good percentage have pet birds, and then there's all these other crazy pets here. So people have pet squirrels, pet monkeys. Anybody here have a pig, one of those pigs that's in the house? Okay, no one admits it. Okay. How about a pet goat? No goats? Okay. How about ferret? Y'all are boring. Okay. How about iguana? Anybody got a pet iguana? Snake? Rat? Gerbil? Anybody have a dog? Okay. Okay. All right. So on the test, if there's a rabbit on the test, pick Tularemia. The rabbit's going to be from Arkansas. Okay? Just pick it. If the kid is like growing rabbits for for whatever, what's that farm thing the kids do? 4-H. Okay. Yeah, if they're growing rabbits for 4-H or whatever, or he's trying to make furs or something, I don't know. And the kid gets sick with this big lymph node, just pick it. Okay, it's Tularemia. That's what they're trying to tell you. Yes, you can get these other things, but they want to ask you about this or the rabbit. All right, rodents. So mice and rats, it depends on where you live. So if it's a kid who lives in New Mexico or a kid who is in the desert Southwest and they're cleaning out garages for people and there's rat urine, then you're going to be worried about things like leptospirosis, or you can be worried about hantavirus, things like associated with rat urine, or plague if they get a big bubo. The big one here, though, is this LCM, lymphocytic chorial meningitis with guinea pigs and hamsters. And the reason is that about 2 years ago, there was this woman who died, and she donated her organs. Yep. And you guessed it. And she had a hamster, and she ended up having I guess she had viremia with lymphocytic chorial meningitis, and all the people who got her organs got this. So it made MMWR, so there's big news things in the ID world. So people go, oh yeah, I forgot about that. Let's ask that on the test again. So anyway, it's probably due again. So just remember, lymphocytic chorial meningitis associated with hamsters or guinea pigs, okay? All right, turtles, we already talked about iguanas. Ferrets, all right. No one here has a pet ferret? Okay. These are really cute. I'll show you the picture in a second. But the big deal about them, okay, 5 to 7 million ferrets in 4 to 5 million homes. Okay, so ferrets can transmit rabies, influenza, which is interesting. And if you look at ferrets, someone did a study looking at ferrets, 18% of them have Campylobacter. Okay, so a great board question would be, someone's got a pet ferret, they get diarrhea, and then they get Guillain-Barré. What do you think the ferret had? Campylobacter, okay? The other thing is this, tuberculosis. So here you've got this cute little ferret. It coughs on you. You're kissing it. It's coughing. How are you going to? So here's the cute little ferret. So you put it on therapy, but you got to keep a mask on it. While you're letting it run around the house or whatever. Okay. All right. So Q fever. This is Coxiella Burnetti. gram-negative Coccobacillus. It's intracellular pathogen. The big deal about this is, so what can happen is you can get it from, like, people will travel to Australia, whatever, and get this wool. They get the wool from Australia, and it can be, the organism can survive in the wool for like over a year, or if there's like tick feces in the wool, whatever, for whatever reason, it can survive in that. So people go, travel, get the nice wool, fresh wool, and, you know, these blankets or whatever, and they get exposed this way. Or more likely on the exam, it's going to be a kid, an adolescent who lives on a farm, and he's helping with cattle or sheep who are having babies, okay? Because this is where you're exposed to it. Most of the cases in the U.S. Are in California, at least half. So some kid who works in a farm out there. Again, cattle, sheep, and goats. Dairy herds, nearly 80% are infected, and cats. We've had outbreaks with cats. So the classic story with this is in the Northeast. Actually, I think it was in Canada, and they had this family reunion, and they said, oh, you know, the cat is having kittens. Let's bring all the kids around and show them how wonderful life is, and, you know, the birthing of new babies. And so they all went and looked at it and everything. Well, the cat had Q fever. The problem with Q fever is it's in the placenta, and so with the birthing of the animals. And so all these kids are there. It gets aerosolized, and they all got Q fever. So anyway, they're fine. So just to remind you, of the anatomy of the cow, okay? So remember, so what happens is with cattle is that, remember, frequently there's a breech delivery. And so you remember Billy Crystal, okay, from that movie City Slickers? So he had to go up in there and help that poor cow deliver. So he's going to go all the way up to this uterus up in here, all right? So half his body's in there. This is where, and there's the placenta right there, and that placenta is just covered in Coxiella, all right? So this is where you get Coxiella from, is exposure to the placenta, okay? So think of Billy Crystal in the movie. This is the classic pneumonia with a big spleen. So another one, pneumonia with a big spleen, like we saw with Cydicosis, fever, chills, you know, whatever, but pneumonia with a big spleen. You just do serologic tests, do a blood test for it, and look for fourfold rise. So here we'll talk about fourfold rise and titers. And most people resolve, but if you diagnose it, you treat them with the weird antibiotic tetracycline. Okay. So last question here, and then we're going to go let you go home. So Billy Quartz develops Q fever. He was likely exposed to which part of the livestock that he works with? Was it the tongue, the leg, the hoof, the placenta, or the infected part? You idiot. Let us go home. Okay. All right. All right. Exactly. Okay. All right, good. Okay. We're going to finish up here this last hour of ID with a few more of the zoonoses, and then the very end we're just going to go through kind of antibiotics, how to think about antibiotics on the test, and how to approach just different disease topics about how you might figure out what they want you to know or what they were trying to get you to treat with. So let's just jump right in here. And for those of you at home watching this on video, yes, my shirt has changed because it's a different day. So, and I spilled food all over my shirt from yesterday, so I couldn't wear it again. So anyway, they'll be like, well, you just changed from red to green. So, all right. So, so we're going to talk about Cydicosis here. Okay, we mentioned it briefly yesterday. And this is a weird parasite because it's a parasitic bacterium. And what's kind of weird about it is that this has both DNA and RNA, but it can't make its own ATP. So it's kind of a weird little critter. 100, 200 cases a year, so extremely rare, except on board exams. Okay, so we have to cover it here. Most people you're going to have something in the case scenario about birds. Okay, this is the bird disease. All right. The key is the birds may or may not be sick, and we acquire the infection when we are cleaning out our bird cages. Okay, so those of you who have birds, any people here have pet birds? A few people have those. Okay, just when and again, the birds may not be sick, so you come in contact with the bacteria when it gets aerosolized as you're cleaning out the bird. poop. You can also get, the good news is if you're handling sick birds, you can get it that way, which hopefully you're not handling a sick bird. I guess veterinarians are going to be at risk for that. And then foodborne transmission, though, luckily, has not been documented, so that's a good thing. All right, how do we diagnose this? Again, any of these weird things where you can pretty much just know that serology, you're going to look for some like a fourfold rise in titers. That's always a good way to go. Pretty much any of these weird infections you can do that way. So that's something to just remember kind of in the back of your head. Easy little tip for the test. The treatment is tetracycline, doxycycline. All right, just briefly on avian influenza A or the bird flu. Most cases are due to H5N1. There's other things, and the problem is that this H5 part is the part that's the problem because we don't have antibodies to that part of the organism. And so if you're exposed to something you don't have antibodies to, and particularly if a whole community is exposed to it, then you're likely to see a whole lot of disease. And that's kind of what happened 2 years ago with 2009 with the swine H1N1. And now we have the swine H3N2, so we'll have to see what happens over the next couple of weeks here. So far with the avian flu, luckily it hasn't jumped to humans as far as being transmitted between humans very easily. Very limited spread. The key thing I think that they're going to ask us about this on the test is they may say, what's the best way to prevent, if you have a problem with this, what's the best way to kind of stop the epidemic? And the answer is going to be immunize. Okay, immunize people. So hopefully we'll do a better job than we did in 2009. As you know, we had the outbreak in July, August, and then it was like, you couldn't get vaccine. You particularly in physicians' offices, we couldn't get vaccine, but Walmart had it, so it was just kind of crazy. So, all right, this is just from that time period, and this is kind of funny. This appeared in an ID commentary, and this is like a really famous ID person that they interviewed during this time, and we weren't really sure how it was being transmitted, and there was a lot of almost hysteria about it, but probably rightly so because we weren't really sure how if it was going to be transmitted differently than regular flu. So his recommendations were, so if you're on an airplane, so when you go back, or if you're sitting in this room, your options can be limited if you're seated next to someone who's coughing and sneezing. His recommendation is change seats to get greater than 6 feet away, or ask the cougher to wear a mask and turn his or her head away when coughing. So I guess you go to the plane with a mask and you hand them out, Okay, grocery shopping. The recommendations are the virus lives on surfaces such as grocery carts for 2 to 8 hours, and bacterial cultures, as we know, over many years, yields fecal E. coli, which is just, because you remember where the kids sit, right? So the cart that you went and just picked up, some kid just pooped in it, and So his recommendation is wash and wipe cart handles and do not touch your face or your child's face. Perhaps keep a washcloth with diluted bleach solution in a sealed sandwich bag to use as a sanitizing wipe. Okay. All right, this is really good. Doctor's offices. See if you can do this in your community. Many patients in waiting rooms are sick. Recommendation for physicians, set up designated H1N1 waiting room, have coughing patients wear masks, and keep ill patients greater than 6 feet away from other patients. So if you have a waiting room as big as a football field, got those 30 kids in there you're having to see, it doesn't work too well. So speaking of football fields, football games, his recommendation, outdoors is good, but stay upwind of a cougher sneezer. And then transportation. So I guess you're on a train or a bus. If someone's coughing, put tissue or scarf over your mouth and nose and then move away. So anyway. Okay, so we're going to spend a couple minutes on things that we can get from cats on the test. All right, so ringworm. Ringworm. So cats have ringworm. Okay, probably a lot of the kids that you see are getting their ringworm from cats. And then you've seen those cat shows, on TV. And, these are like the most pristine, they're bathed better than anyone in this room. But a large percentage of them have ringworm. So just be aware. If there's an outbreak, or something like that, then look for the cats as the cause, if there's animals involved in that. The big one, though, they love to ask you about is Pasteurella, right, is a cat bite. And so someone did a study, 60 to 75% of quote-unquote normal cats, whatever that is, carry this in their mouths. And it's now the most common organism, okay? It's Pasteurella is number 1, Staph Aureus is number 2. So they like to ask that for some reason on the test. So I would know that Pasteurella is number 1. You're going to treat all cat bites with amoxicillin clavulanate, so just augmentin. What you need to know is they're probably likely to give you that the kid's penallergic, okay? So the kid's going to be penallergic, so you can't use the augmentin. So look for Clinda plus Bactrim. That would be the choice I think they would give you, so Clinda plus Bactrim if the kid is penallergic, okay? All right, these are the other diseases that you can get from your cats here. We won't talk about some of these, but just interesting little things you can get. Cat scratch disease, we talked about briefly. Remember, it's Bordetella henselae. I know that organism name. They sometimes just like to ask you that. You know, what is the organism that causes cat scratch disease? 40% of cats have positive antibodies. You can get it from bites or scratches, and it can be carried by cat fleas, too. All right, these are non-infectious to humans, so sometimes people are worried. You know, they hear that their cat gets diagnosed with feline immunodeficiency virus. Okay, that's not transmittable to humans, so you don't need to worry about if there's an immunocompromised kid in the house or there's an HIV positive kid or family member. These diseases, they don't transmit to humans, so you don't have to worry about that. All right, toxo we need to spend a few minutes on. Remember, as cats are the definitive host. Most of us got, if we got this, we got it when we were young, playing in the sandbox outside. And because the cats go and poop in there, and then we play in the sandbox, and then it gets aerosolized, and we form antibodies. France, for some reason, I guess there's a lot of cats around. 85% of people in France are antibody positive for this. Remember, we worry about this in pregnancy in particular, and that's where the question is likely to come up for you is about the pregnancy issue. And so you need to know kind of what the fetal risk is. So if the mom mom has no antibodies to toxo and she gets infected in the first trimester, the chances that the baby's going to be affected is about 25%. And as it goes on, second trimester, third trimester, the baby has a much higher chance of being infected. Now, the deal is that the severity of the disease is inverse to this. So the later in pregnancy, so by the third trimester, if the baby is infected, it's much less likely to have a problem, as opposed to if the baby is infected during the first trimester, then it's much more likely to be a problem. So less risk early on as far as getting infection, but if you do get infected early on, then you're more likely to have a bad outcome from that. So these are the things we look for in the newborn with toxo, microcephaly, big spleen and liver, rash, retinochoroiditis, and then these cerebral calcifications. And they'll classically ask you, which ones are to go around the ventricles. Remember, that's CMV. And for toxo, it's kind of scattered throughout the brain, so it's going to be just cerebral calcifications, okay? I don't think they'll ask you treatment. They mainly want you to make the diagnosis. Remember, it can look like a lot of the other congenital torch syndromes, but the key thing to help you is these cerebral calcifications, okay, that don't circumvent the ventricles. The biggest thing you do to prevent this is have someone else in the household empty the cat litter box. So that's the main thing. They could ask you about that, is how do you prevent this, is you have someone else empty the cat litter box, because it's aerosolized every time you do that. All right, so this is just, unfortunately, a brain with toxo. So these are the areas that are affected. So just kind of throughout the brain. All right, so this is just a cute little story here. And this is why you worry, why cat, this is the reason why, if you look at these, kind of focus on these fangs here, why cat bites we have to treat. Because if you think about how the cat, it's like fangs, right? It's like vampire. And it goes really, really deep down into the tissue, as opposed to a dog bite, which is usually more of a crushing injury. So it doesn't go down deep into the tissue. So the bacteria are sitting there on the edges of that, goes deep into the tissue, and it sets up shop down in the deeper layers of the skin or in the muscle or in the fat. And so that's where you have problems with. So we treat every cat bite. Okay, every cat bite pretty much is going to get treated. Dog bites, generally you don't have to treat every one of them, but if it looks infected or becomes infected, you obviously are going to, and you're going to use the same antibiotics for that. So this is a cat bites man eating parrot shower. Gerald Daigle, 80, lost a pint of blood and required stitches after his cat Tootie, diminutive, roughly meaning tiny, launched a frenzied attack. Daigle, who was giving his pet parrot a shower, I don't know who does that, inadvertently sprayed the cat with water. Reuters reports that the cat has since been euthanized and had a troubled past. So sad. All right, so now, for dog people, a lot of you had dogs, you said. So these are all the diseases that we can get from dogs, and we'll hit on some of them, just a few. So the big one you need to know is rabies, I think. For sure, they'll probably give you a rabies question. And with rabies, it presents in us is that if you get rabies, you get an acute encephalomyelitis. So get restlessness, excitation, and then remember the big thing everyone remembers is the hydrophobia, and this is because you get severe spasm of the larynx and pharynx when an affected person sees food and water. So some kind of trigger there that causes them to have spasm of the larynx and pharynx. We diagnose this by usually you do a nape of the neck biopsy, looking for Negri bodies. Now, which animals on the test do you worry about? So dogs and cats are the big ones. The Red Book lists ferrets, too, with the dogs and cats. And you need to be suspicious for rabies in any of these groups. So particularly if they haven't been immunized. The big question is if it's a dog, particularly a dog that's not acting right, the dog comes up and bites the kid with an unprovoked attack and then runs away. Generally, you're going to be stuck treating the kid and giving the kid rabies vaccine. If the pet can be held and available for 10 days of observation, then you don't need to do anything. You can just watch it. Now, the guidelines have changed on this, and I think this is important, though. That used to be the answer for every bite. You could just watch it. But now, if the bite or exposure is to the head or neck, so if the kid gets bit on the face, then the recommendations are you go ahead and start prophylaxis. Okay, start prophylaxis, and then at the end of the 10 days, you can stop and not give. So by the end, you've given 3 doses, so you just end up not getting the 4th dose at the end. The reason is because the way rabies works, usually, so you get bit on the hand here, so the rabies, the dog bites you here, the rabies gets into your skin and gets into your nerve. So it's in your nerve here, and it's got to travel up the nerve path from your hand to your brain. And so that takes longer than 10 days, okay, for that to occur. It's a very slow process. That's why we can wait the 10 days before we give the immunization or the immunoglobulin. The problem is, in theory, is that if you get bit on the face, this is much closer to your brain. And so the theory is that this actually could get there before the 10 days. So it could get from here to your brain before the 10 days is up while you're waiting. So that's the new recommendation. So if it's to the head or neck, the recommendation is that you go ahead and start prophylaxis while you're observing the animal. Okay, obviously if they get bit by, a raccoon that's, out in the garage, or a skunk or a bat, then you want to consider them rabid, and you're going to go ahead and start therapy for them. Now, large rodents, rats, mice, okay, a cow bite, livestock, rabbits, generally you're not going to worry about, okay? You can consider on an individual basis. The public health may say, oh, we found, there's tons of rabies in the community, so you better go ahead and do it. Maybe this animal got exposed. But in general, you're not going to be worried about rabies from one of these kind of bites. And then non-mammals like Sammy, an iguana, or a snake, they don't carry rabies, okay, because it's only in mammals. The classic one on the test is the bat found in the room. Okay, so the family's gone camping, or they're out in a tent, or they're in a cabin, and they wake up and they go in the kid's room, and then there's a dead bat on the floor. And so the recommendations are to go ahead and give prophylaxis. Okay, so the bat found in the room, you give prophylaxis. There's usually no sign of a bite, but that's just what the recommendations say, so just do it. All right, what do we give? We give rabies immunoglobulin and then rabies vaccine. I wouldn't worry about memorizing the dosages. They're not going to ask you to discriminate between that on the test. But just know you need to give the immunoglobulin and you give vaccine on the same day. Just remember to give them in separate sites. Okay, so give it on days 0, 3, 7, and 14, and we've taken away the 5th dose now, so all you need is 4 doses. All right, leptospirosis we mentioned briefly yesterday with Jethro swimming in the pond, and the deal here is that go with this infection. Remember Hawaii, if Hawaii is mentioned on the test, that's something that is your clue to be thinking about this. Rats, dogs are the main ones that carry this, and remember immunized dogs can excrete in their urine. And what happens is it penetrates your mucous membranes and incubates for 7 to 12 days, and then it just spreads all over the body. Remember, this is a spirochete. And they develop jaundice, renal failure can occur, uveitis. But if you see this word here, these 2 words, conjunctivals effusion, okay, know those 2 words. If they say those 2 words, this is the only disease that does this on the test. Okay, just pick leptospirosis. You see that. Here's what it looks like. So you can see the jaundice here, right? You can see the jaundice, and then you got this effusion here, okay? So this is a conjunctivals effusion. This means lepto. So early on, the spirochetes are running around the bloodstream mainly, and sometimes the spinal fluid. So early on, 4 to 7 days, is when you would do the blood culture. You'd look for it in blood culture. Well, here they're generally not going to show up because they just have a mild influenza-like thing. It's here in the immune phase. That's when they develop the jaundice and the uveitis and the rash. And then you need to know you want to check the urine. So the urine's where you're going to look. Okay. You can also do serology. You can also do this urine test for it, but urine's where you want to go for. It's going to be in the urine. Just like the dogs, it's going to be excreted in their urine. All right, Toxocara. This is intestinal roundworms of dogs and cats. What happens is that the puppy, or usually it's seen in puppies and kittens more often, but the eggs are excreted, and then it's in the dust and the cracks of the floor. And so, the kid's crawling around all over the floor. You're crawling around on the floor chasing after the kid. And what happens in children, generally 1 to 4 years of age, is they get visceral larva migrans. And the classic thing is you got this shifting pneumonia going on. Okay. So the history here for the puppy I've listed for you, it's very complicated. It's amazing this organism can survive to go through all these things. But eventually, this is its whole life cycle in the dog or the cat. The deal is when we ingest it, we're a dead-end host. Okay, it doesn't go through this whole process with us. So it's trying to complete its process, ends up in our lungs, and that's why you see this shifting pneumonia. So in humans, it's migrating aimlessly, trying to complete a cycle, and it just isn't going to happen in us. And what you'll classically see on the exam is fever and cough. They'll show you a chest x-ray, or say a chest x-ray, where the infiltrates are shifting around, moving around. They'll give you a high eosinophil count, and they may give you a high IgG. The clues is the eosinophil count. Okay, it can be 40 to 50%. They also may give you the elevated immunoglobulins, and then you also can have elevated isohemoglutins to A and B, which is kind of, if they see that, then they're really trying to help you out, figure out this is toxo. There is an ELISA test, so you just do a Toxocara ELISA, and treatment's going to be albendazole. Okay, tapeworms. This is where we ingest dog or cat fleas that contain the larva. And you're saying, well, how does that happen? I'll give you a pictorial in a second so you can figure it out. And what happens is we get abdominal pain, a little diarrhea, and you get this worm that forms in our large bowel that's 4 to 28 inches. So, 4 to 28, that's a pretty good sized worm. So this is how it happens. How many people here have pets? Okay, how many of you sleep with your pet? Okay, a few of you are admitting it. So what happens is you go to sleep with your pet, you sleep with your mouth open, the pet comes and lays next to you, the cat or dog flea jumps off of the cat and jumps into your mouth and you swallow it. Okay, so this is how you ingest cat fleas. Okay, so that's your pictorial. So it goes like this. Whoop. All right. But if you're going to get a worm, if you're going to get a worm, you might as well just go for it. Okay, just get a good worm. If you're going to be impressive, get a worm. Good worm. So this is from eating pork that's not properly cooked. Okay, and what happens is the eggs are eaten by the pig. The eggs hatch in the duodenum, ends up in the muscle. The larvae end up in the muscle of the pig, and we don't cook the pig meat as well as we should. We eat the pig meat. The larvae attach to our small intestine and mature, and then we get this nice worm that's 4 to 9 feet. So that's what you want to, if you're going to get a worm, just go for it. I mean, get the 8-foot worm, all right? So this is why I went infectious disease. This is I think, the funniest quote ever. And this is from parasitology. I remember as a second-year medical student, parasitology. This was in my little parasitology book. And this quote about this, he says, infection is ordinarily asymptomatic except for the discomfort, inconvenience, or embarrassment resulting from the gravidoproctids crawling out of the anus. So, anyway. All right. Heartworms occasionally going to show up on the test because what will happen is you'll get a chest X-ray and you'll see this coin lesion on an adolescent. Usually it's an adolescent boy. So you see this coin lesion. They live in the South. And what happens is it's spread by mosquitoes. And the dog heartworm is deadly, obviously, to them. But to us, we're dead-end hosts, and it just ends up in our lung. And you get this coin lesion. So lots of cases of it seen. So it's not, we don't worry about it. It's not like a coin lesion in an adult, that's a 35-year smoker. You'd be going, oh gosh, this is cancer. You just ignore this. This is your dog heart anatomy, just in case you didn't know that. All right, fish and shellfish. Just a couple things we talked about already. Mycobacterium maritim, remember, don't forget that one. That's probably the big one they're going to ask you about with that. All right, West Nile virus. Just to show you how things can spread across the country. So this is from 1999 to present. So this is 1999, before some of you were born. And this is where we had our first cases. All right, so we knew something new was going on, and this came over from Africa and was started being spread by mosquitoes here in the United States. So this is 99, and the red are the human cases, and the blue are the animal cases. And then in 2000, it's like, okay, it's just this, it's still this little issue up here in New York area, pretty much. And then by 2001, you can see it spread into Florida. Okay, well, how did it get here? Birds, migratory patterns of birds. So the birds brought it down to Florida during the winter, and then when the mosquitoes came out in the spring and summer, they started spreading it to humans. So this is 2001. 2002. Same thing, okay? So you can see how something can spread, like if bird flu is something that is going to be spread within birds and eventually jumps to humans, how easily it could be spread across the country. So this is 2002, 2003, 2004, and then we keep going through. And then this is last year's data, and they've just done it by county. And as you can see, it pretty much what happened was everyone got antibodies over here in the east, and then it spread to the west, and so most of the cases we were seeing were in the west. Well, now we've got a whole bunch of people who don't have antibodies again, and so we're seeing cases again. So, there's cases now in Texas here and the rest of the South. So it's just something to be aware of. They might ask about on the test. Most people that deal with this, it's hard to do a question about West Nile. It's because 80% of people who are infected, like most of us probably are infected in this room if you got mosquito bites during those years. And we were asymptomatic. So we just formed antibodies and we went on our business. So 80% of people who get West Nile are asymptomatic. So you can't really have, hi, I'm asymptomatic. Oh, you have West Nile. I mean, you can't do that. So most people, if they get sick, so the other 20%, if they get sick, they just have this mild flu-like illness. And then the 1 in 150 is what you worry about with the neurologic disease, okay? And that's the ones that are worrisome. And this is where they get the fever or the mental status changes and this rash, weird little rash. And the problem is they develop ataxia and these ectopyramidal signs, okay? So early in the community, if you want to diagnose it, and so what's happening again, we're having to figure out is this what's going on, because you're seeing cases of encephalitis in the community, is you need to do an IgM antibody. So you just do an IgM again, remember. IgM means it's acute disease, and you're going to do it on the serum and the spinal fluid. And once you know what's going on in the community, you don't need to waste the resources you're going to see lots and lots of cases after you know it's there, and so you don't have to necessarily confirm everyone with a diagnosis. Treatment is supportive. Unfortunately, there's no treatment, but for you, that's good news on the test. You don't have to remember anything as far as that goes. As far as cases by age, when we're having it at the peak, as you can see in the pediatric age group down here, it's not that common. It was around 10% of cases in 10, 11-year-olds. The big group was people my age or a little younger than me who we're seeing most of the cases in for whatever reason. So as far as fatal cases, in pediatrics, not too many, but there are some, especially in the 0 to 9 age group. We've had some fatalities from West Nile. All right, so just remember it's mosquito-borne, and look for it in the summertime on the test. I think that might be how they present it to you as just a possibility. Just real briefly on mad cow disease in honor of the Olympics in London. They first diagnosed this in cows in 1986, so this has been around a long, long time now. It peaked in 93 they were having 1,000 new cases a week in the cattle there, and by 97 it had dropped. And what they did is they figured out what was going on, so they did a feed ban. They destroyed all the cows that possibly might be infected, and they kind of started over from scratch. And the other thing is they had any animal that was going to slaughter, they had them inspected by veterinary surgeons to make sure that they weren't acting weird, which is interesting. I mean, I don't know how I grew up on a farm. I don't know how you tell a cow's weird. I guess if they're ataxic, it's pretty easy, but, All right, so the kind of scary part, though, with this is we knew that parts of the cow were infected with this, and, unfortunately, these are parts that we like to eat. And so all these parts of the body were found to probably have, this BSE in it. And luckily for the English, tongue was not one of them, so they can still have tongue, cow tongue. And so we didn't use none of these parts of the cow were used in human food or animal feed since 1990. Now, what happened is they still, until 97, though, kept using cosmetics. So they put in lipsticks and, eye makeup and things like that. And they were still using it in pharmaceutical and medical products. So kind of interesting. All right. But the big deal was in April 6, 1996. And Lancet had this landmark article where they described new variant CJD. And it's the key thing here for you on the pediatric boards is generally it is going to be a young person, like 17, 18, 19. They'll be from England probably, and they're going to present with dementia and ataxia. So if they give you a young person from England who's presenting with ataxia and dementia, be on the lookout for it. There's very few cases anymore, and there's 15 to 20 cases back in the 2000s. Now they're down to around 3 to 4 per year. In North America, we've had some cases. We had a total of 15 in North America between 93 and 2007. So again, very, very rare, but for the board's purposes, they might put it as an emerging disease thing for you to look at. The other thing is, as you know, we've had cases here in the United States. This is a case that was in Washington State. We've had one in Alabama. And their concern was that we'd have problems with it here. So far, luckily, we've been able to keep things under pretty good control. All right. So these are just some healthy pet ownership things for you. And then, would you let another human slobber all over you? Where's your dog, cat's mouth been? If you sleep with your mouth open, reconsider sleeping with your pet, or at least make sure they wear a flea collar or something. All right, so which of the following pets would you most like to have? A dog, a cat, gerbil, ferret, or rock after hearing this talk? Okay. Okay. All right. Okay, the last part here. Now, this is I've given you in the back. If you go past the antibiotic jeopardy part, I've given you the answers to these, so you don't have to spend so much time jotting everything down that I say, because I know it's a lot of information here. And this is kind of just free flow anyway, so I want to make sure you get the right answer in your handout. And so we don't have to spend a lot of time just going over things again and again. This is mainly going to be, what I want to do is just kind of present a bacteria to you, and then I want you to think what would be the best antibiotic to use against that bacteria, okay? So we'll just kind of run through some of these in the last 30 minutes. So the category is penicillin here. You form your answer in the form of a question, and for $100, what antibiotic is used for strep pyogenes? So what do y'all think? Okay, so first thing is on the boards is they don't say group A strep. They'll say strep pyogenes. So I want some old gray-haired person says they need to know strep pyogenes. Okay, it's like, okay. So just know it's group A strep. So how do we treat group A strep? Okay, penicillin, right? So just look for penicillin. Look for penicillin, PenVK, ampicillin. Okay, just look for that. All right. They may give you, try to get all fancy on you too and go, well, this organism has a penicillinase resistance. And all they're telling you is this is Staph aureus. This is methicillin-sensitive Staph aureus, okay? So before, when we first came out with penicillin, it killed staph just fine. And then the organism got smart and developed a penicillinase, which pretty much, caused the penicillin not to work. And so it's Staph aureus now. So regular old methicillin-sensitive Staph aureus produces this penicillinase. So what's the best penicillin, IV penicillin, to use against that? Okay, nafcillin or oxacillin. Okay, so look for nafcillin or oxacillin on the test for that. Okay, and then the gram negatives came on, and they said, well, we're tired of penicillin too. We'll fix it. So they made a beta-lactamase. Okay, and so there's 3 different drugs that are available. Okay, there's Zosyn, right? There's Timentin, and then there's Unison. Okay, and all 3 of those are just, what it is like Zosyn is piperacillin, tazobactam, and Timentin is ticarcillin, clavulanic, and then Unison is ampicillin, sulbactam. And that sulbactam, that tazobactam, and that clavulanic added on is just a beta-lactamase inhibitor. Okay, so the drug company got smart, said, okay, we'll just add this inhibitor with this antibiotic that used to work, and it'll work just great. So adding that inhibitor, what it does is it improves your gram-negative coverage really a lot, but also gives you anaerobic coverage too. Okay, so Unison, Zosyn, Timentin, they all have good anaerobe coverage. Okay, and remember, Zosyn has really good Pseudomonas coverage. Okay, that's the one claim to fame for it. Okay, the oral penicillin effective for Pseudomonas. So, they give you the kid who stepped on the nail and it went through the tennis shoe, and and you're worried about Pseudomonas cellulitis, or they have a cellulitis and you think it's Pseudomonas, and they give you all these choices of penicillins, oral penicillins, because the kid's not that sick and it's just it's a little cellulitis. So don't put Augmentin, okay? And that's what most people, you need to use something else, okay? Remember, the oral penicillins don't cover, Augmentin does not cover Pseudomonas. Okay, Augmentin does not cover Pseudomonas. Right? So there's really no oral drug here except for a quinolone. So if they're older than 18, you're fine. But if they're younger than 18, you're kind of stuck. Okay, you're going to have to use something IV like Zosyn, or you can potentially talk to if it's a 16-year-old, talk to parents about the risk-benefit of Cipro in a 16-year-old. All right, how much do you want to wager? All of it? Of course you do. All right. So it's on computer, so they may have you draw something. I'm just teasing. They're not going to make you draw anything on the computer with a mouse. So just some of you are freaking out, like, oh, I don't remember it. I want to remember it now. Well, there it is. Don't worry. Don't memorize this, please. All right. But they're more likely to ask you this. What's the best and cheapest aminopenicillin for Enterococcus? So what do we use for Enterococcus? Okay, ampicillin, right? Ampicillin. So remember in the babies, that are less than 3 months of age, and we always make sure we have ampicillin on board because it's going to cover Enterococcus and it's going to cover Listeria. Okay? All right, I'll give you this list, just the things that penicillin are still good for. So you can kind of go through this when you get back home. Again, that was so that you've got this. All right, so weird infections. So they're going to throw some things that maybe we talked about them, and you've forgotten, or maybe they just put something on there. So, so the best treatment for tularemia. Okay, and the kids, let's say the kid's not that sick. Okay, generally, if you don't know, just pick doxycycline. Okay, so doxycycline is always a good choice. Now, if the kid's sick, you want to look for streptomycin or gentamicin is what they might give you. But if the kid's not that ill, doxycycline. Best treatment for Q fever, doxycycline. Okay, you see the pattern here. What's the organism for Q fever? Coxiella Burnetti. Okay, they may just ask you that. I mean, sometimes they ask you just crazy things. Best treatment for Ehrlichia. Good. See, you're getting it. Okay. All right. And how this presents from a tick bite, and what does it do to the cells in the blood? They're all low, right? You get pancytopenia with Ehrlichia. Okay. Best treatment for Rocky Mountain, doxycycline. Someone asked me yesterday, which is a good question. You know, what do I do about the 6-year-old with Rocky Mountain spotted fever? Do I use, you know, am I worried about using doxy? Well, you're worried about it, but the problem is you can't get chloramphenicol anymore anyway. So, you know, if the test had it as a choice, I guess you could pick it, but it's not really readily available. And really, a short course of doxy that you're going to use for these type diseases isn't going to cause any problem. So most people are pretty comfortable using them for short course in children because it is better, and chloramphenicol you just can't get anymore. All right, we didn't talk about this, so best treatment for this, what is this? What is Bordetella? Okay, pertussis, right? Okay, so azithromycin, most people have gone to using azithromycin for this. They could give you erythromycin still. Okay. All right, a patient with a UTI. So here's where they give you a kind of a little scenario, and let's say this is a 6-year-old girl. Okay, so what might be a good choice? Okay, Bactrim. Yeah, I mean, Bactrim would be fine. You could use a cephalosporin, you know, one of the cephalosporins maybe if you wanted to, if she was sulfa allergic, you know. So there's a lot of choice. If she's sick and she has to go in the hospital, what would be a good choice? Okay, like ceftriaxone would work, or clafuran would be good. So clafuran, 3rd-generation cephalosporin. I mean, the other thing is, when you're trying to figure out what to do, what's the most common organism here? Okay, E. coli, right? So you just need to think of an antibiotic that's going to get E. coli, right? So just think about that. Now, let's say it's a 1-month-old. Okay, so what other organisms do we throw in here now? Okay, so Enterococcus, again, remember we need to be worried about that, right? So what antibiotic might we add to our clafuran? Ampicillin? Okay, good. Okay, an infected central line. So the first thing is, what do you think, what's the most likely organism going to be? Staph. And what kind of staph? MRSA or MRSE, right? So methicillin-resistant staph, epi, or methicillin-resistant staph aureus. Because they're obviously, if they got a line, that means they've been in around hospitals, okay? So they're likely to have resistant organism. So what's the best treatment for MRSA or MRSE? Vancomycin, right. If they had a fungus in here, what would you need to do to the central line? Take it out. Good. All right. Okay, endocarditis in a 16-year-old drug addict. All right, so here you got to think about what's the hardest thing I have to treat. Okay, so what's the most likely hardest thing you think? Like staph, right? So Staph aureus, particularly MRSA. So you're probably going to need like vancomycin. You probably want to start with vancomycin. And then the other thing is you've got to worry about Pseudomonas in this group. Okay, so you might start them on aminoglycoside maybe, or you might start them on Zosyn or something really broad spectrum. But you're going to need really, really broad coverage for this kid because he's exposed to a lot of resistant organisms. So Vanc and Gent, you know, you might use as a choice here. Okay, meningitis. Let's make it a 14-year-old. 14-year-old kid with meningitis. What's your empiric therapy going to be? Okay, Vanc and ceftriaxone. Okay, Vanc and ceftriaxone. All right, what if we make it this is tricky. Let's make it a 2-month-old. So they've been home in the community for 2 months. So what do you want to use? Many people would use three drugs here. So they use Vanc and ceftriaxone because the kid's been exposed to pneumococcus in the community now for a while. And then you would still probably use the ampicillin. So you might use AMP, Vanc, and ceftriaxone in the 2-month-old. Okay. All right. So what are you worried about in this patient? What are you worried about in this patient? So neutropenic patient, gram-negative. Which gram-negative are you worried about? Pseudomonas. Okay. So what's a good choice here? Okay, Zosyn. Zosyn would be good. Maxipine, cefepime. Okay, do not pick ceftriaxone, right? Ceftriaxone, Rocephin does not cover Pseudomonas. Okay, you're not going to pick that. Okay. This you may or may not know. This is imipenem. Okay, imipenem, or Primaxin. Imipenem. Mainly we see it in you want to be careful in using it in kids with renal insufficiency. Okay, so if they've got renal insufficiency, they have a higher risk of having seizures with this drug. Okay, what does this? Rocephin. And that's part of the reason why, there's some concern, or there's concern about using ceftriaxone in younger kids, less than 2 months of age, is because of the biliary or bilirubin problem with it. It's probably more theoretical than real, but, many times we steer away from using ceftriaxone in that age group just because of that concern. But it can cause some problems with the gallbladder occasionally. Okay, so classic thing they'll ask you about with amphotericin B. So what are the two electrolytes you worry about? Okay, potassium and magnesium. Good. Potassium and magnesium. Okay, so they tell you the nurse calls you and says that this kid is just all red now. Okay, so what do you think caused it? What antibiotic? So vancomycin. And the mechanism is if you infuse vanc too rapidly, okay, it causes mast cells to release histamine. So they turn red. So all you have to do is slow down the infusion and give them Benadryl, diphenhydramine. Now, the key thing here is the nurse calls and says, well, do I need to put in the chart they're allergic to vancomycin? And the answer is no, okay? So it's not an allergic reaction, okay? It's a reaction to the antibiotic being infused too rapidly. So you just slow it down, give them some diphenhydramine, they're fine. Okay, this macrolide can cause significant hearing loss. Okay, erythromycin, and one reason we kind of forgot about it until we had that cases of Legionella were appearing in some older kids, and Legionella, and you were having to use high dose of erythromycin, like 1,000 milligrams, Q whatever, and they would start have hearing loss. Okay, usually it's reversible, but just keep in the back of your mind that it can cause hearing loss. All right, so this is my point with this question is you're going to remember a lot of really stupid things, okay, and a lot of facts when you get back home. And this will be one, but you'll also remember things that actually be on the test, I promise you. So how many people remember which toes? Fourth, okay, see? So this is how good you are. See, your short-term memory is it's stretched now. We're almost 18 hours almost, and you still remember something. So that's good. But the point is that, if you can associate some of these things that you have trouble remembering with something silly or something in your mind to remember it, it makes it easier to remember. So if you can associate some of these things that you have to remember with something that, is easy or funny, then it helps sometimes. Okay, they might still ask this, what binds to the 50S ribosomal subunit of the bacterium? This is classic PEDS board's nightmare question, right? Pharmacology. So this is erythromycin. Okay, erythromycin. Okay, so how do you treat Lyme disease in a patient with third-degree heart block? Okay, the cardiologists are going, you put a Pacerin, okay, which is right. And what do you treat them with antibiotic-wise? Ceftriaxone, okay, ceftriaxone. So remember with Lyme, so meningitis, carditis, you're going to use ceftriaxone, and then pretty much everything else you can use doxycycline or amoxicillin. Okay, if you see this aminoglycoside on the test, you know the patient has cystic fibrosis. Okay, if you see them using this antibiotic on the test, you know the patient's got cystic fibrosis. So tobramycin, okay, it's the only time we use it. Tobramycin in general is a cystic kid. And the reason is we really know the pharmacokinetics with Tobra in cystic kids, and it works really, really well against Pseudomonas. Okay, so tobramycin. Okay, how good is your Pfizer rep? All right, so remember azithromycin. Okay. Okay, there's just an iguana sitting there. So what organism are you worried about? Salmonella, good. Okay. Okay, organism found in a cat's mouth that is not a normal human inhabitant. Okay, so Bordetella or Pasteurella, right? So most common thing in a cat bite, Pasteurella. Okay, most common thing in cat scratch disease, or the cause of cat scratch disease, Bordetella. Okay, don't get those confused because they may have them both in the question. Okay, organism responsible for visceral larva migrans. Mumbling. Toxocara. Remember that was the cat flea, the flea jumping from the little kid, or from the cat into the kid's mouth. All right, can cause a pseudoappendicitis. Okay, good. Yersinia, pseudotuberculosis. Okay, or Yersinia pseudoappendicitis, Yersinia enterocolitica. Okay, how much you want to wager? Good, go for it. So viral meningoencephalitis occurring after exposure to this animal. Okay, y'all remember? Lymphocytic choriomeningitis. Okay, lymphocytic choriomeningitis. Okay, some other weird infections they could throw at you. So Pneumocystis pneumonia. Okay, so here, if doxycycline's not there, then the other choice to look for is Bactrim. Okay, so trimethoprim sulfa. So, right, trimethoprim sulfa, good. And then what if they say that the kid's hypoxic? What do you want to add to that? Steroids. Okay, good. Okay, mycoplasma. Okay, doxycycline, right? Doxycycline works good for it. Erythromycin, azithromycin, any of those work well. All right, C. difficile toxin-induced diarrhea. Okay, let's say the kid has a white count of 20,000. So what do you want to do? Okay, good. Vancomycin. Remember, the guidelines change so that if the child is sicker, you want to start with vanc first instead of metronidazole. If they're not that ill, use metronidazole. And then for your recurrence, what do you want to use? Same thing. So whatever you use the first time, just use it again the second time. Okay, how do we treat listeria? Okay, ampicillin, and then you would add aminoglycoside too initially. It's Ampingent. Chlamydia pneumonia. How do we treat that? Doxycycline. Okay, there's this weird, this name here you don't recognize. Just pick doxycycline. Okay, erythromycin, azithromycin works. Okay, who sang the song Cat Scratch Fever? Ted Nugent. Good. All right. Okay, this effect occurs with aminoglycosides against gram-negative bacteria in which bacterial growth is suppressed for a period of time after the level of the drug falls below the MIC of the bacterium being treated. It's a classic PEDS board question where they'll give you some definition of something and then say, what is this? Okay, and this is the post-antibiotic effect. Okay, and in simple terms, what it means is if you give an aminoglycoside, which many of you are using once daily aminoglycosides, this is why once daily aminoglycosides works really well. Okay, it's because you give the aminoglycoside, and what happens is it kills the bacteria really well. The MIC is way above the MIC. Okay, but then the amount of gentamicin in the bloodstream drops, but it drops below the MIC for the bacteria. But with the aminoglycosides, it still keeps killing the bacteria. Okay? So even though it's below the MIC for the bacteria, it'll continue to kill that bacteria. So it's called the post-antibiotic effect. So the nice thing about it is you can give once daily, you reduce the risk of renal insufficiency. All right? So the post-antibiotic effect. Okay, this is just a pet peeve. I'll turn it in every year to the boards. They haven't done it yet, but they might. It's Gentamicin. So if you've been writing gentamicin with a Y all your life, you've been doing it wrong. So anyway. Okay, you swim in a pond with 12 dogs. You develop an infection from a spirochete. What antibiotic you want to treat, use to treat? Okay, so there's a couple things here. So a spirochete. So you can kind of use your brain a little bit here. So what's the most common spirochete that you treat? Syphilis. Okay, so what do we use to treat syphilis? Penicillin. That would work fine here. What else do we use to treat syphilis with? Doxycycline, okay, if they're penallergic. So, doxy is most likely what they'll give you, but penicillin would be okay too, all right? The two adverse effects with aminoglycosides, okay, remember hearing and kidney. It's always good if you don't have a clue and they've got something going on. It's the kidney and the ears are always together, okay? Remember, there's that Alport syndrome and there's all these weird things, and it's always the kidneys and the ears that go together. Okay. So osteomyelitis, what do we say is the most common osteomyelitis, cause osteomyelitis? Staph aureus. Okay. So you're thinking, okay, I'm looking for oxacillin or I'm looking for vancomycin in the question choices, all right? And they don't have that there. Because what they likely will give you is this antibiotic because the cephalosporins, as you know, particularly this one, is very cheap, and we only do it 3 times a day. Okay, so if it's methicillin-sensitive Staph aureus, look for cephalexin, okay, Keflex. I'm sorry, cefazolin. Cefazolin is IV form. So cefazolin is what you want to look for. First generation. So Keflex. I'm sorry. Ancef. I'm having a TIA today. All right. So cefazolin. Okay. On the test, so they give you a kid with Enterococcus, Listeria, or MRSA, and this last one's changed a little bit, but they have all these cephalosporins listed, right? They have all these cephalosporins, okay? And you just need to know, like particularly the one they will give you every single time and say, don't you want to use ceftriaxone? And you don't, because it doesn't get this, right? All right, so ceftriaxone does not cover everything in the world. So, and it doesn't cover Enterococcus, Listeria, or MRSA. There's a new cephalosporin, but it's not approved for kids, so you don't have to worry about it. All right, that does cover MRSA. So you're home free. You don't have to worry about it. A patient allergic to penicillin is likely to be allergic to cephalosporins by this percentage. So this comes up on the test. Is what they'll do is they'll say, Johnny had this rash 5 years ago, and now you need to treat his meningitis with, he has rash to penicillin, ampicillin, and now you need to treat him with ceftriaxone. And they say, well, can you do it or not? And what do you think? Yes. Okay. The real risk is about, it keeps shrinking each year, like to 6 or 7%. Now, if Johnny had anaphylaxis to penicillin, okay, I'm not going to probably want to use a cephalosporin. I'm not going to chance anaphylaxis. But, the classic he had a little rash to penicillin, you're not going to worry about that on the test. You're going to use cephalosporins. Okay, agents good for Pseudomonas in the cephalosporin class. So how many people want to use ceftriaxone? No, please don't do that on the test, okay? All right, so cefepime, maxipime, okay? Fortaz, ceftazidime, although there's been resistance with that, so maxipime is probably the one they'll give you, okay? Maxipime, cefepime. Okay, your daily double. So the methylthiotetrazole side chain impairs recycling of vitamin K and can cause hypoprothrombonemia in these 5 antibiotics. Name 2. Well, I'll give you them because I can't pronounce them anymore. And half of these aren't available anymore. The deal about this is you've got, generally these are, if you look at the drugs, most of these are used by the surgeons, right? And so the story is they'll give you this 15 or 16-year-old, and the kid's got some underlying nutritional deficit going on, and they're vitamin K deficient already. And you use one of these antibiotics here, and what it does is it impairs the recycling of vitamin K. And so the patient becomes even more vitamin K deficient, and they say he's oozing from his lines. Okay, so he's bleeding from his lines. All right, and it's these kind of antibiotics that do it. So cefotetan is probably the big one still that they might give you. So it's usually on the surgery floor, and they're calling you as a pediatrician to come figure out what's going on with this kid. The other thing is you need to know with any antibiotic for long term can impair the gut as far as the recycling of vitamin K. So someone can become vitamin K deficient with that as well. Okay, so quick no-nos here. So guess what the answer is? No. All right. So theophylline and Cipro, so here let's say you have this older asthmatic who's on theophylline for whatever strange reason still, and is 18 or 19, and then he gets the UTI, and someone puts him on Cipro. You don't want to do that because you're going to get theophylline toxic. So you don't use these two together. Okay, Cipro, they might try to get you to use an 18 or 19-year-old kid for pneumonia. Know that we never do that anymore. So you need one of the newer drugs like Levaquin for like a 19-year-old with pneumonia. Ketoconazole, H2 blockers, no. Keto and as well as Sporanox, itraconazole we talked about yesterday. Remember, you need an acid environment for it to be absorbed. And then IV Cipro, again, I don't think they'll ask you too much about quinolones, but if they do, this might be one. Remember, oral quinolone gives you just as good as IV as far as levels. And then Astrinam, if they have it on the test, it's just usually there. Just know that it only gets gram negatives. Okay, it's kind of a weird antibiotic they may throw on you. Some of you never use it. Some of you use it all the time, depending on what your hospital can afford or what their contract is. So occasionally they'll have that. All right, your last question here. Ready to wager all your money? I know y'all can get this one. No. Okay, so what is this? Pinworms, good. All right, here's the eggs. Here's the Scotch tape thing. And then how do you treat that? And that's a fancy name. Okay, mebendazole, but remember, mebendazole is gone now, Vermox, so albendazole is probably what they might give you, although the board still might give you mebendazole because everything's available on the board still. So we're done with ID. All right.